Assalamu alaikum and good evening to you all. Welcome to the Health Talk on Acute Medicine, organized by ACP Bangladesh chapter and supported by Bangladesh Society of Medicine. Today, we have come to the 10th episode of our series. There was a break due to the examination, but we are continuing the series with full pace from now on. On this episode, we're going to talk about a disease which is known as the mother of all diseases. Yes, we are going to learn about the emergencies in diabetes mellitus. To talk about this important topic, we have one of the best clinicians with extraordinary clinical skills with us. He is none other than Professor Khaja Najimuddin sir. He is the Professor of Medicine and Honorary Senior Consultant, Bardem General Hospital and Ibrahim Medical College. To chair the session, we have our very own Governor-elect of ACP Bangladesh chapter himself. A true leader, a prodigy in the field of medicine, Professor Khan Abul Kalam Azad sir. He is the former president of Bangladesh Society of Medicine. As the panelist, we have two most renowned professors of our country. Firstly, we have someone who is famous for his extraordinary diagnostic skills, Professor M.D. Golam Kibriya sir. He is the Professor of Medicine, retired Dhaka Medical College. We also have the amazingly talented Professor M.D. Asadul Kobir sir. He is the Professor of Medicine, Dhaka Medical College. To moderate today's program, we have the beauty with brain, Dr. Samira Rahat Afroz Apu. She is the Registrar of Medicine, Bardem General Hospital. During this live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Samira Rahat Afroz Apu. Dr. Samira Rahat Afroz.
Assalamu alaikum, respected viewers. Thank you, Dr. Prince Kausar, for your lovely introduction. It is a privilege and honor for me to be able to moderate such a prestigious session on acute medicine tonight. Without any delay, I would like to first invite Professor Khaja Najimuddin sir, Professor of Medicine, Honorary Senior Consultant, Bardem General Hospital and Ibrahim Medical College, to please start and present your valuable lecture, sir.
Thank you, Dr. Samira and Dr. Prince. I wish to start thanking ACB Bangladesh Chapter Governor, my most favorite, Professor Nazmullah sir. With due respect and regard to my most favorite, Khan Abul Kalam Azad, as the president of this session, chairperson, all of them who are present here in conducting the session, Dr. Samira, Murat, Ibrahim, Prince, very favorite. Samira is very much favorite to me because he worked with me in Bardem. So the topic as told is the most important one for an internist. If you do not know diabetes, better we should say you do not know medicine. So we'll be talking about the complication. Before going to any other introduction, let's go for hypoglycemia. You know that hypoglycemia means reduction of blood glucose in the blood. But before starting, I want to tell a story. You say how this can happen. That is long before the Samorita Hospital when it was started. In its initial days, in the OPD, two giant professors of medicine that time were standing, a patient with his relative crying and crying, a woman with her daughter, brother, and husband came to the OPD. Now, first of all, one of the professors saw him, the second other son examined him. They told that yes, patient is dead, very little to do. It was a stroke, so you will have to accept it. The relatives. There was one young man, very young doctor, but he was 4 years senior to me. That time he was young, and he was working in Martin. He noticed there is a book, guidebook with the relatives. So we went to the patient. Without further delay, he started glucose, injection glucose. Within few minutes, the patient sat on the chair, sat on the trolley, and he started talking. This is how we can confuse. This is how we can be misguided. This is how hypoglycemia presents. This sort of things happen many times, many days to pass. Just confusion happen along with hypoglycemia. There is no damage of the brain, but the appearance is like that. With this, let us start. These are the symptoms you can get, everything you can get. Irritability, dizziness. In the morning, every day you are getting headache. If you go to retrospective, you will see there is some sweating at night and disturbance of sleep. So that is due to hypoglycemia. We get this patient. You see, that day I was coming with a man, diabetic, Baden stop. He used to take insulin. He was walking with me from Baden to Green Road. In the middle of the road, he stopped talking. And he was talking irrelevantly. Because I know him, so I asked him to take some sugar like this. So there is trouble taking, confusion, loss of consciousness, even seizure and death. About 5% death occurs. But I have not seen a patient die of hypoglycemia during my 10 years work in body. Usually there is feeling of hunger, sweating, shakiness, weakness, and most important is the symptom develop very quickly, very quickly. These are the facts, first fact in fact. একটা ভদ্রলোক যখন এরকম করবে তখন মনে হয় বেটা ড্রাঙ্ক। যখন একটা গরিব মানুষ এটা মনে করবে তার ইটিং ডিসঅর্ডার হয়েছে। এটা মনে রাখতে হবে যে আমরা রোগীকে বলি তোমার ডায়াবেটিস নাই, তোমার হাইপো হতে পারে না, এটাই মনে রাখা ভালো। এটাতে মানুষ অজ্ঞান হয়ে যাবে। These are the clinical manifestation. One is neurogenic symptoms. I should say this is autonomic neurogenic symptom. Another is neuroglycopenic symptom. Neuroglycopenia occur when the brain becomes deprived of glucose. That is called neuroglycopenia. Neurogenic is when autonomic arousal occurs. You see, obviously there are symptoms here. You can see it. But problem is these symptoms are non-specific. There are many other diseases, many other conditions can produce this symptom. That is why the Whipple tried. Whipple's tried, the man Whipple, he introduced this in 1930. There was no estimation of, there was no way to estimate hormones, insulin, C-peptide, corticosteroid, PSAs. So he was a pancreatic surgeon. Whenever he was doing surgery, he had to exclude hypoglycemia. So he introduced this triad. Patient had symptoms of hypoglycemia, as I told. When it is measured, there is low blood glucose, and the symptom resolved after correction of hypoglycemia. This is, you can see obviously there is a response, autonomic response of hypoglycemia. There is sharp difference, contrast at daytime and nighttime. Nighttime, there is parasympathetic overactivity, so there is bradycardia, bradyarrhythmia. ventricular premature beat, and pre-left to beat. And at night, at daytime, there is simple adrenal response. So tachyarrhythmia, cardio acceleration, prolonged death. See, here I can say something. There are studies to control strict to have strict control blood glucose and to see the effects on CBD outcome. There is ACCORD trial, advanced trial, VADT trial. They had to abandon this trial because hypoglycemic response was like this and death was occurring. So they had to abandon it. So, and this is the most important thing of hypoglycemia. You will reduce blood glucose, but not to the level below a certain level that can trigger this autonomic response. Signs symptoms are you can memorize like this. But what I do, I say the patient, you'll feel hunger like eating everything. Whatever you get, you will have. You will feel shaky, you will sweat, you may become unconscious. You see the well was being around in hospital, patient with insulin, I heard talking. The patient is talking, telling his children, give me water, give me some glucose, give me some glucose, otherwise you will lose me in 10 seconds. You see, the hypoglycemia experience is very bad. Hypoglycemia experience is bad. Must sometimes my patient to doctors. Yesterday I had a visit with Azrael. I had a talk with Azrael. I just came out of Azrael when I took the glucose. This is like this. So hypoglycemia, once somebody experienced, he tried to escape insulin and other drugs. It is very difficult to someone to convince once someone is hypoglycemia. So inside history is like that. You can get hypoglycemia with condition of more insulin, with condition of normal insulin. We will discuss it later, and the subsequent will get the C peptide, and you can differentiate this. So classification, it is not grade or stage, it is level. Level 1 is glucose less than 70 milligram and more than 54 milligram. That means glucose level of 50 milligram of 70 milligram level is recognized as a threshold for neuroendocrine response to following glucose in patient without diabetes. Patient with diabetes না থাকলে এই লেভেলে হয়. This level is considered important in lieu of severity of the symptom. Glucose less than 54 or 3 millimole is threshold at which neuroglycopenic symptoms begin to occur. This is the threshold to develop neuroglycopenic symptoms. And 70 is the threshold where you need to treat it. A severe event characterized by altered mental and physical status requiring assistance from another person for recovery, it can progress to loss of consciousness, seizure, coma, and death. This is level 3. So level 3 is no specific glucose threshold. There is hypoglycemia associated with severe cognitive impairment requiring external assistance. Level 1, level 2, and level 3. Very important things. So management is glucose in any form. Fine sugar or glucose, either oral or IV injection, oral glucose, and other one is glucagon. For your information, glucagon is not available in our country, but there are some places, 2 places. One is Bardem 2, where type 1 diabetes management is going on. So you can get glucagon there. And probably Evercare Hospital is keeping the glucagon. Glucagon is the thing because we'll tell you later, you can give it, anybody can give this injection, IM or subcutaneous, and there is rapid action of it. So our treatment is glucose, and glucose in any form. Strategy 15 rule. which means eating 15 gram of fast-acting carbs, waiting 15 minutes, checking your blood sugar, if still there, and give 15 gram again, till blood sugar returns to at least 70 milligram per deciliter. These are the examples of 50 grams of carbs to treat hypoglycemia. You do not have glucose, you do not have sugar, but you can take any one of these, like a slice of bread, small piece of fruit, a cup of oatmeal, a tablespoonful of sugar, half a banana. So schematic, if you go to schematic representation of emergency management of hypoglycemia, symptom consistent with hypoglycemia, test capital blood glucose. If less than 70, treat it. If you cannot test it, you treat it with hypoglycemia. Whenever you are in confusion, whether it is hyperglycemia or hypoglycemia, you give glucose. Because there is no harm having higher glucose, but very, very harm having hypoglycemia, lower glucose, 10-second brain damage occur, brain deterioration occur. So if you get an unconscious patient, administer glucose by the subcutaneous intramuscular route. Once consciousness is recovered, take slowly absorbed carbohydrate to prevent repeat hypoglycemia. If patient is conscious, follow rule of 15. Administer 15 gram of glucose or equivalent. Capillary blood glucose after 15 minutes. Blood glucose below 70 still, repeat glucose intake and measure blood glucose again 15 minutes. Blood glucose above 70 milligram, take slowly absorbed carbohydrate supplement to prevent repeat hypoglycemia. So how will you follow it up? Random blood glucose after 15 minutes if normal, observe with complex diet. If it's still low, repeat glucose intake till random blood glucose normal, then on complex diet. Carbohydrate with high protein. Suppose question can arise, will milk help? No, because milk contains protein. Protein increases insulin secretion, so it will increase hypoglycemia. Milk contains fat, it will decrease the absorption of carbohydrates, so it is not effective, it should not be used. Observe for 24 hours plus, more than 24 hours, if someone is with long-acting sulfonylurea or long-acting insulin. Don't maintain with 10 or 15% DA if recurrence anticipated. In our practice in Bardem, we have given many patients 1 or 2 days 5% DA. Now, reduce the dose up to half or decrease 20% of insulin. Do not omit insulin. So please do not omit insulin. What happens? You see the doctor, the sister, nurse on duty ask the patient, this patient has blood sugar less than 5 or less than 3 or less than 4. The duty doctor says, so stop insulin. No, it is not like that. If the insulin is like that, if night insulin work on the morning sugar and morning insulin work on the day sugar. So if you omit the morning insulin, it will not help the morning sugar. Rather, it will increase the daytime sugar. There will be spike. So be careful about this. Substitute long acting with short acting if feasible. Relax target to control for at least 3 months. Best for those with 65 years or who have hypoglycemia awareness. Dictum is if somebody has severe hypoglycemia, once you delay for 3 months to come to the normal dose. If one had not severe but 2 times of mild to moderate hypoglycemia, still you delay. Those who have prolonged time of diabetes, they are like to have a hypoglycemic awareness. So target should be relaxed for them for control to avoid hypoglycemia. Things to remember, as I told, you tell patient if you feel hunger like taking everything, so this is hypoglycemia. If you feel tremulousness, it is hypoglycemia. If you have sweating, undue sweating, yes, it is hypoglycemia. If you see somebody is talking to you, but all of a sudden it changes mood, so this is hypoglycemia and treat that hypoglycemia. If there is lateralization, left-sided hemiparesis, left facial palsy, unlikely to be hypoglycemia because there is no brain damage. Prognosis, metabolic problems, so brain disturb mostly reversible. I have not seen anyone having permanent brain damage with hypoglycemia. Even patient come from outside. I know one man from Pabna. He came second or third day. After 1 month, he went back in normal way, normal movement. Cause of death is cardiac due to autonomic overactivities. Death in bed, it happened at night, as I told you before. So mostly cause of death is cardiac. That is why this trial of accord, adverse, and BDT was abandoned. Those who are habituated with higher glucose may develop symptoms at higher level. This we can remember, not 70, even up higher level. Never take symptoms lightly, especially if elderly. Now, question is theoretically DPP4 inhibitor, metformin, acarbose, buglivose, they only work when with food. If there is food, they secrete insulin, they sensitize insulin. They sensitize insulin and glucose goes down. So theoretically, they should not develop any hypoglycemia. But practically, blood glucose low may be milder symptom. That as I have told, because they are always with high blood glucose. So with these drugs may also, but usually there is combination of drugs given. Metformin 1.5 hemoglobin A1C reduction, DP4, acarbose, all like this. So when you give combination, you will get 3 hemoglobin A1C reduction 3. So there is most likely to have hypoglycemia, even without insulin, without sulfonylurea. If a relative of diabetic patient call from home, ask first to take glucose, then move to healthcare facility. I had a patient who called from Mohammadpur. I told them, you give glucose and come to hospital. They started. When came to hospital, they become patient were unconscious. I asked them, did you give glucose? Oh, no, I didn't. I told them, but they didn't. This is likely. If you are ambiguity, give glucose first, then resuscitate. Exclude hypoglycemia, even the cause of unconscious is obvious, that is stroke. Whatever the cause is, just try to exclude hypoglycemia. Glucometer reading of glucose, low glucose must be confirmed by sending a sample to laboratory, because glucometer is glucometer. It is always erratic in test. So far we have told about the diabetic hypoglycemia. It is most common. In fact, whenever patient come with symptoms of hypoglycemia, I tell if you have no diabetes, if you are not taking any drug of diabetes, it is unlikely that you have hypoglycemia. But truth is different. There are non-diabetic hypoglycemia also. There is one is spontaneous hypoglycemia, another is reactive or postprandial hypoglycemia. This is most common. Not common thing, but these two we encounter. So what are the causes of spontaneous hypoglycemia? One is fasting hypoglycemia. This happens with this alcohol, drug, critical illness, hypopituitarism, and adrenaline insufficiency. Another is not fasting, but there is hypoglycemia. This is truly spontaneous hypoglycemia. How can you diagnose them? Just taking history that he or she is not diabetic, and then examination of insulin and C-peptide. Both insulin and C-peptide increase, most likely it is insulinoma. This is insulinoma. And when there is insulin excess but C-peptide low, then it is exogenous insulin. This is deliberate taking insulin or sulfonylurea poison. If both insulin and C-peptide low, as I have told before, no insulin, or this is fasting hypoglycemia. These are the severe condition of the patient that can lead to hypoglycemia. So, sorry, what we learn, fasting hypoglycemia, medicines, alcohol, serious illness, low level of certain hormones like cortisol, growth hormone, glucagon, and some tumor who secrete insulin like growth factor also can produce fasting hypoglycemia. But fact is, prolonged fast, more than 72 hours, if there is no hypoglycemia, then it is not. If there is no hypoglycemia, so it is not a spontaneous hypoglycemia. This is a diagnostic test. Absence of biochemical or clinical evidence of hypoglycemia exclude spontaneous hypoglycemia. Once hypoglycemia confirmed, a sample of blood should be taken for later measurement of insulin, alcohol, C-peptide, cortisol, and sulfonylurea. Because you are a specialist, you must have in your mind there is term spontaneous hypoglycemia. Whether she takes insulin, whether she takes tablet, it is unlikely if he is not diabetic he is taking this. But we can take this for sampling because they can get its poisoning also. This is, you see, this we get sometimes in our practice. We get some patients say after having sugar, after having food, after having meal in the daytime, most of the days I get this shaking or tremor, rapid heartbeat, especially this rapid heartbeat and panic, hunger, mouth tingling like hypocalcemia, sweating, headache, and nausea. This is nothing but a term reactive hypoglycemia. This is another name is glucose sugar crash. Is a term describing recurrent episodes of symptomatic hypoglycemia occurring within 4 hours after a high carbohydrate meal in people with or without diabetes. The term is not necessarily a diagnosis since it requires an evaluation to determine the cause of hypoglycemia. So explanation is sporadic high carbohydrate snacks and meal are deemed the specific cause of sugar crashes. The crash one feels is due to rapid increase and subsequent decline in blood sugar in body system as one begins and ceases consumption of high sugar foods. More insulin than actually is needed in produced in response to large rapid ingestion of sugar foods. So for each diagnosis, you need a test of mixed meal tolerance test. This is first you have to a special drink containing protein, fat, sugar. The drink raises your blood glucose, causing your blood body to make more insulin. Then your blood glucose level is checked a number of times over next 5 hours. We have said it's 5 hours glucose tolerance test to diagnose the spontaneous blood glucose or fasting hypoglycemia. Another thing nowadays it is available continuous glucose monitoring. So how to prevent not only reactive hypoglycemia, all hypoglycemia, avoiding or limiting sugar intake, high sugar intake, binge sugar intake, eating a variety of foods, eggs, nuts, lentil meats, whole grain carbohydrate, more fruits and vegetables, eating more high fiber diet, does not usually require medical intervention and only to treat the cause. Exercise regularly. Exercise increases cellular sugar uptake, which decreases excessive insulin release. Avoiding eating meals or snacks composed entirely of carbohydrate. Simultaneous ingest fat and proteins, which have slower rates of absorption. Consistently choosing longer lasting carbohydrate, monitoring an effect of medication if it produces symptoms. So these are the practical examples what I told like before. Called over telephone for unusual behavior of an old woman with diabetes. So you ask them to give sugar and bring to the hospital if possible. After surgery, a patient became erratic. You see, some surgery, usually elderly patients become delirious. Sometimes become delirious. But it happened with me while I was working in the garden. I used to give glucose. You give glucose, it becomes alright. Once it happened, so I gave glucose. Even after giving glucose, I saw her blood sugar is 6, random blood sugar. So it was definitely this. And you see, my neighbor that called me to see her husband who is on dialysis and confusion stage. What should I do? I will ask him to go to hospital. I'll ask him to give insulin glucose. Nothing is available. So what we tried? We tried opening the mouth in give glucose drink with a spoon, giving and giving, abandoning hope. He became all right after half an hour. So young doctor came with her sister involving 4 to 5 episodes of confusion. So this is an example of insulinoma. Insulinoma is a very small tumor, 5 to 6 millimeter. It can be detected by CT scan or MRI, otherwise difficult. And biochemical testing, as I have shown, you do C peptide, you say insulin, you will get the results. But insulinoma is a practical term. There is medical treatment for it also. In David's it is very nicely told. In this event of COVID-19, I have got 2 or 3 cases. And the doctor called me and asked me. I didn't go there, but he told me it is happening like that. What can I do? And we gave this dioxide treatment. We tried to find out the cause. So this is the summary of hypoglycemia. Low blood sugar caused by these things. Symptoms: treat with 15-15 rules of carbohydrate and glucagon. You see the more method of giving glucagon. Inject at 90-degree angle into thigh or buttock. This is very easy. Anybody can give. You do not need a medical person to give it. You do not need a nurse to give it. The student friend, the housemate, everybody can give. That is why it is called easier to give. So without diabetes, you can have some hypoglycemic symptom that is sometimes called reactive and spontaneous. So far, we have told about the hypoglycemic emergency. Now let us switch over to hyperglycemic emergency. There are two terms, decay and hyperglycemic, hyper smaller state. Though you used to tell honk before, but nowadays mostly hyperglycemic, hyper or smaller state is told. So this triad we will tell later. Hyperglycemia is here, both the condition, but other two are different. Now we see the differential for diabetic emergencies. This theoretical we can say, but practical it is very difficult to differentiate. You can ask many emergency officers, many, they will say it becomes sometimes very difficult. So how to take the history? Onset, hours to days, in minutes, hypoglycemia. Appetite unchanged, but he wants to take everything. Thirst increased, there is no change. Muscle tone decrease. Hypoglycemia, you will get plantar extension and tremor. Skin texture, skin is very dry. Patient will say hyperglycemia, I cannot eat. Mouth become dry. The tongue to fix to the heart palate, like this. Respiration, hurried, typical respiration. I have seen many young patients, not older patients, and it is unchanged. This is nicely shown, its figure, attractive figure, decay and hyperosmolar hyperstatic. The statistic is not exact because the death in hyperosmolar hyperstatic is higher. And the process of glucose development is glycogen breakdown in the liver, so glycogenolysis, and gluconeogenesis from broken protein and lipid. So glucose is higher, it goes into the urine. There is osmotic diuresis, there is excess urination, so there is electrolyte imbalance, dehydration, excess thirst. And this rise is due to counter-regulatory hormones, glucagon, epinephrine, cortisol, and growth hormone. So this is the medical media. Allele are given it. So what is diabetic ketoacidosis? A serious medical problem which happens in people with diabetes when their body starts to run out of insulin. So one of the factors is lack of insulin. It happens with the younger patient. When this happens, substance called ketone builds in the body. It can be life-threatening and it is not found and treated quickly. So characterized by hyperglycemia, hyperketonemia, and metabolic acidosis. Hyperglycemia causes osmotic diuresis, significant fluid and liquid. Decay is diagnosed by detection of hyperketonemia and metabolic acidosis and presence of hypertension. Treatment likewise a non-volume expansion, that means dehydration, insulin replacement, and prevention of hypokalemia. Because the younger group died of mostly cerebral edema, elderly group died of hypokalemia. You see, many times in my practical, I have seen sugar high, sodium low, and potassium high in initial presentation before doing ketosis, blood gas analysis, before doing the keto. So I presume that it may be a case of ketoacidosis. When I was intern, the patient mostly these people came to what about whoever I have seen, they can at 1:30 to 2 or 2:30. I asked the professor what can I do. He told we just give one saline, normal saline, and keep on giving that time human, I mean actapate ASM. Nowadays all insulin are human, so actapate ASM is not written, only actapate is written. So this is just remember if you have high glucose in the patient, if you have sodium low, potassium high, this is the initial presentation of diabetic ketoacidosis. Common physiologic stresses that can trigger PK. Number one is infection. Usually we give antibiotic invariably, but it not always happen. Myocardial infarction, stroke, pancreatitis, pregnancy, trauma, some drug in pain. You see, I give one example. When I was I was seeing patient inside the bay. They called me to see one patient. The patient was admitted for myocardial extensive anterior myocardial infarction. When blood sugar was examined, it was very high, 24, and there was ketoacidosis. And patient was in shock. So I told, so see the blood culture also. TCDC in MI it comes high, it infection comes high. So that patient has pseudomonas, non-erogenous strobilia. So subsequently, that patient was diagnosed as melioidosis, MI, acute MI, and diabetic ketoacidosis. So you must have in mind only not only MI but ketoacidosis also can present symptoms. And nowadays the SGLT inhibitors are used. Even normal glucose, you can get the symptoms of decay. So what is the pathology? Number one is insulin deficiency. Number two is glucagon excess. Next is there is resultant osmotic diuresis due to hyperglycemia and excretion of ketone. So what insulin do? There is no insulin. Body tries to mobilize triglyceride amino acid instead of glucose for energy. Serum level of glycerol, free triglyceride rise because of unsteady fat lipolysis. As does alanine becomes from muscle catabolism. Glycerol and alanine provide substrate for hepatic gluconeogenesis, which is stimulated by the excess of glucagon accompanied insulin deficiency. Now, glucagon also stimulates mitochondrial conversion of free fatty acid into ketone. Insulin normally blocks this ketogenesis by inhibiting transfer of free fatty acid derivative into the mitochondria. But ketogenesis precedes the absence of insulin. So, major ketoacid is produced as acetoacetic acid, beta hydroxybutyric acid, and strong organic acid that create metabolites. Acetone derived from metabolism of acetoacidosis accumulate, remain, and is slowly disposed by respiration. And one thing we can say that whenever we get a patient with decay, immediately we do not get the urine ketone positive because this ketone is derived from acetoacidic acid and beta hydroxybutyric. It takes 1 or 2 days to get the acetone abandoned in the urine. Hyperglycemia due to insulin deficiency causes osmotic diuresis that leads to marked urine loss of water and electrolyte, and urinary excretion of ketone also obligate additional losses of sodium potassium. So we get polyuria, we get electrolyte disturbance, we get hyperglycemia and hyperketonemia. So this is the ketogenesis, both from glucose and triglyceride. This is acetyl coenzyme, and that lead to acetone and beta hydroxybutyric acid, acetoacidic acid, beta hydroxybutyric acid, and acetone. These are three ketones. This is a very simple thing, but very good explanation. Without insulin, glucose is unable to be processed by the body. So pancreas comes from insulin comes from pancreas. Then what does the other organ? Liver produces more glucose to feed the body. But without insulin, glucose accumulates in the bloodstream. Body cannot use glucose. Body needs to find out an alternative source of energy and starts breaking down fat. The breakdown of fat produces ketone, which then build up in the body. So ketone and glucose are in the blood. This you may say this is an undergraduate thesis, but this is not there is no harm to learn it. ketones and glucose are transferred into the urine. Kidney use water to clear blood from excess glucose and ketone. So this is very nice explanation on pathogenesis. While the body attempts to get rid of ketone and glucose, a lot of water is lost. This can lead to dehydration and may worsen the ketoacidosis. So you can recognize DKA by the following things: feeling tired and sleepy, blood pressure, confusion, stomach pain, abdominal. Many times we get DKA with abdominal pain, usually younger child, needing to pee more often than not, being very thirsty, sweet smelling like nail varnish or pear drop sweets. Pear drop sweets is a candy. You will get in most of the in our place it is not available, but Western country you will get a cheap candy, two colors. One is red and another is yellow. And high sugar level. Feeling nausea, vomiting and stomach pain, feeling confused, being sleepy and loss of consciousness. এগুলা কখন আমরা পাবো? Whenever we get it. Because we practice with diabetic patient, we get patient with sugar on glucometer they measure, we see their sugar is very high. So examples of risk factor. কি কি হতে পারে? Prolonged exercise, pregnancy, gastroenteritis, having an infection, alcohol intoxication, and illegal drug use, and prolonged fasting. So there are conditions which you need to treat immediately. How to prevent decay? It is important to recognize potassium K symptoms, risk factor, higher risk situation. If you experience any of the decay symptom or you encounter high risk solution, you better go to hospital. Test your blood glucose level frequently, every 2 hours. Test your blood ketone levels. একটা জিনিস আমি বলি, if you examine with the glucometer, when it is high, it will show high, and it will ask for K ketone. It will ask for ketone Ke. So glucometer will give you warning. High sugar means 300 milligram. In fact, when I was going through this, they are telling 250 milligram, and this machine will ask to do ketone body. So it is written test your blood ketone levels. So higher risk situation are situations that requires extra awareness and should trigger you to test for it. During illness with fever and vomiting, vomiting you should do it. When blood glucose level is more than 250, when you are frequently urinating, days where you do not manage to control your blood glucose. We have got so many patients. They are taking 3-4 medicine, lot of insulin, but still sugar is not under control. So this is the term we should remember. Uncontrolled hyperglycemia can lead to ketoacidosis. This is here pathogenesis. We have told it before. Two things. One is insulin deficiency, another counter-relative hormone excess. These are the precipitating factor. There is gluconeogenesis, there is glycogenolysis, less utilization of glucose, and hyperglycemia and ketosis in the body. But there is one more thing along with this, there is pro-inflammatory cytokine produced that increase the counter-regulative hormone actions. And they give birth to glucose from muscle and adipose tissue. And liver produce the glucose, liver give it in the blood, and there is ketone excess, there is MSC, base loss, and ketoacidosis called hyperventilation, there is osmotic diuresis. This is schematic. And in diabetic ketoacidosis, we get intracellular dehydration, we get extracellular volume depletion, we get shock, we get less GFR, and acidosis, and increased burn and decreased electrolytes. So what are the facts of diabetes? First sign of 20% of type 1 diabetes. We are lucky that type 1 diabetes is less in our country, so we get this less. But when I was in Saudi Arabia, I got patient. Type 1 diabetes presented with decay. Number one risk is lack of health coverage. Yes, this is number one, definitely number one. You see, in burden, they are providing 30% of the patients free treatment to cover this risk, but it is difficult to cover. There are 200,000 cases in US every year of decay. can become full-blown in few hours. We saw in hypoglycemia in few minutes, 10 minutes, you can get everything. And here, hours. We'll get in hyperglycemic state in days. So criteria is ketonemia more than 3. Less than 3 is not significant. And urinary ketonuria 2 plus. Blood glucose more than 11. Not that you will have to get 16, 70, 30 glucose. No. Even if it is just 10 millimolar, that means random sugar, then it can cause ketoacidosis. Bicarbonate less than 15. And venous pH, venous and arterial pH very little different. So you can do venous pH less than 7.3. These are ketoacidosis. So there are three things. A lack of insulin. Without insulin, your body begins to break down fat items to get energy if needed, a process that ultimately results in dangerous buildup of acids. When this happens, your body gets rid of this with diuresis. So when we are going to manage this decay, we have to learn corrected sodium. It is written in Davidson also. You see, we get in hyperglycemia, we get false hyponatremia, or you can say the CR. Only sodium is less, potassium is normal like this. So how you correct this? Illustration. Suppose somebody have blood sodium 120 milligram. Be attentive to learn this. Serum sodium 124 milligram per liter, and glucose is 600 milligram per deciliter. So for 100 milligram of deciliter, 100 milligram of sugar above normal, above 100, will have to add 1.6 millimole of sodium. Now he has 500 milligram of sex, so 1.6 into 5 is 1.8. Is 8. So if he or she had sodium measured 124 with blood sugar 600, so actually his sodium is 124 plus 8, that is 132. As acidosis is corrected, serum potassium drops. That I told you before. You get sodium low, potassium high initial times. As initial potassium levels less than 4.5 indicates marked potassium depletion and requires immediate potassium supplement. So not only hyperglycemia, electrolyte like sodium and potassium also important. How to say severity in terms of pH? Severe is below 7. Moderate is 7 to 7.25. Mild is 7.5 to 7.3. If you go in terms of bicarbonate, severe is below 10 bicarbonate millimole per liter. Patient may gain stupor or coma. Bicarbonate 10 to 15 is moderate. Patient may have drowsiness but not coma. And mild is 15 to 18. You see, diabetic ketoacidosis is an emergency, but coma term is not used because, in fact, I got many patients come walking to me having diabetic ketoacidosis. So how we do this? Mild, moderate, severe. Though the management is same, but we can categorize them like this to see the prognosis. Plasma glucose, pH, bicarbonate, ketone, and ion gap, osmolality, mental stress. Osmolality, when it is measured, but when we do it, is osmolarity. We calculate it. When it is measured, it is osmolarity. So indication of severe diabetic ketoacidosis. This was a question in this year in FCPS. Blood ketone more than 6, bicarbonate less than 5. We got less than 15 is ketoacidosis. Venous or arterial pH less than 7. We got ketoacidosis less than 7.3. Hypokalemia on admission less than 3.5. We got 4.5. Glasgow Coma scale score less than 12. Oxygen saturation on air is 92, less than 90. Systolic blood pressure less than 90. Heart rate either more than 100 or less than. As I told you before, there may be sympathetic overactivity or parasympathetic. And anion gap is more than 16. These are the indication of severe diabetic ketoacidosis. So, marker of decay severity and association. Degree of acidosis কখন বেশি হবে ডায়াবেটিক কমপ্লিকেশন হলে লঙ্গার হসপিটাল অ্যাডমিশন আইসিইউ অ্যাডমিশন ডিউরেশন হসপিটাল অ্যাডমিশন কখন হবে বয়স যাদের বেশি প্রেজেন্স অফ কোমরবিডিটি যাদের বেশি প্রেজেন্স অফ ডায়াবেটিক কমপ্লিকেশন বেশি ডিউরেশন অফ ইন্টারভেনাস ইনসুলিন থেরাপি কোমরবিডিটিতে ডায়াবেটিক কমপ্লিকেশন সো হাউ উইল ম্যানেজ ডায়াবেটিক কিটোঅ্যাসিডোসিস আমরা আগে ভাবতাম চারটা জিনিস চারটা পিলার ফ্লুইড insulin, electrolyte, especially potassium, and triggering factor treatment. Now, this is a maneuver. Actrapid. A is airway breathing circulation. C is common circulation resuscitation. T is treat potassium. R is replacement of insulin. A is acidosis management. Actra P. P is prevent complication. I is information for patients. D is discharge and rapid. So airway breathing circulation as per any emergency. DK patients need to have their airway breathing and circulation assessed immediately. It does not mean it need to be admitted in the ICU, but better to manage in HDU. A decreased level of consciousness may lead to an unprotected airway and compromised breathing. The osmotic diuresis can cause significant loss of fluid, leading to severe dehydration and circulation. Furthermore, severe electrolyte deficiency significantly increase the risk of life-threatening cardiac arrest. So, HDU is, we can say nowadays, it's available, mandatory. But thing is, if someone says, it happened in my life. I was working in Saudi Arabia as district manager, Thana level hospital. That was long before, There was a medical specialist. He was at that time 56 years old, and I was 34. So there is a rule there. If you get a bad patient, you refer it to the central hospital. Even the director was telling, I did not see that time lot of patients of DK. Only I was working in PG, postgraduate hospital at CA. I saw one or two patients. One of them was my relative of my friend, but he unfortunately died while we were managing this case. So the director asked me to transfer him to central hospital. I was in favor of that because I was the GP. But that man, he told me, I am the last person to transfer this patient to manage DK. He told like this. Then, in fact, he managed him in that Thana level hospital and patient become all right. So, what is the use of this lecture? If somebody like me get in a patient with DK in Thana level hospital, if he transfers it, if it is not severe case, if it is not a pregnant case, if it is not a patient with other infection or comorbidities, if it is not respiratory infection, other things, he or she should not transfer immediately, instantly, or at first instance. He should try it. Then suppose he transfer it to the district hospital. The consultant told there is no HDU here, so let's send it go to central hospital. Central hospital told there is no ICU here, so send it to Dhaka. If it happens like this is very bad. Professor Abul Kalam Azad, Dr. Nazmul Hasan is trying to prevent this. We should learn this and we should be acquainted with this. So next is commence fluid resuscitation. The amount of fluid resuscitation required in severe ketoacidosis is often the amount of fluid that is lost. It is severe decay. We learn it is 6 liter. Davidson says it is 6 liter. Half of the fluid resuscitation volume is initially replaced quickly over first 12 hours, and the rest is administered in the next 16 hours. We calculate like this: 2 liter in first 2 hours, then 2 liters in first 4 hours, like this, then 12 hours, like this. So 2, 2, 2. You divide 2 to first 4 hours 2 liter, next 4 hours 2 liter, and next 12 hours 2 liter. But you give the fluid rate according to the state of the patient. In decay, you may need to give fluid 1 liter in half an hour. First, like the dengue hemorrhagic shock, dengue hemorrhagic fever. According to the condition of the patient, it is given. Initial fluid may be 1 liter in half an hour. So fluid assisted resuscitation also independently decreases blood glucose level, increases renal perfusion, increases tissue perfusion, and decreases intravascular osmolality, reducing the fluid shift from the intestinal special to the intravascular space. Treatment potassium, due to increased level of ketones in the body, there is an increased level of extracellular hydrogen acidosis, which are in exchange for intercellular potassium in an attempt to help metabolic acidosis to improve. Due to osmotic diuresis observed in decay, potassium is then excreted by urine, eventually leading to an overall depletion of potassium in both intravascular and intracellular space. Potassium levels therefore need to be closely monitored and replaced as required, usually with an intravenous potassium infusion. But potassium should not be given with bicarbonate. That we should remember. So this is a chart. How will you replace potassium? Amount of potassium to be added to each liter of replacement fluid in milliequivalent. More than 5, no supplementation. 4 to 5, 20 milliequivalent. 3 to 4, 40 milliequivalent. So if it is less than 3, whole insulin, infused potassium 10 to 12 milliequivalent per hour. Still serum potassium more than 3.3. Then add 40 milliequivalent per hour liquid fluid infusion. So যদি 3-এর কম পটাশিয়াম থাকে তাহলে ইনসুলিন দেওয়া যাবে না, কারণ ইনসুলিন আর গ্লুকোজ একসাথে দিলে পটাশিয়াম আরো কমে যাবে। The replacement of insulin is the cornerstone of rectifying decay, as it allows the uptake of glucose as an energy source, thereby reducing hyperglycemia, stopping the pathophysiology of gluconeogenesis. However, blood glucose levels should not be decreased by more than 3 millimole per hour. This is to ensure that the osmolality of the blood glucose not change too quickly, resulting in the rapid movement of the fluid from the intravascular space into the intestine. Thing is, we should remember this. Rapid correction also difficult, also bad, leading to one of the biggest complications associated with decay management, that is cerebral edema. Acidosis management, usually we do not. I have never given bicarbonate to a patient. Acidosis is only actively managed by administering bicarbonate if the pH is less than 7. Although there is no evidence showing a benefit in clinical outcome for patients with decay. As the ketone levels decrease via fluid resuscitation and insulin therapy, the acidosis will improve on its own. As blood glucose level will usually return to normal range before the ketoacidosis is resolved. This is important. Ketoacidosis takes time to resolve. Insulin therapy should be continued until ketones are reduced to an acceptable level. Likewise, blood glucose level should be continuous unless and until there is a ketonemia is done. That is why dextrose is given in management of this. So this is a protocol. May appear to clumsy, but this is most important thing. Usually, we try to keep it on the door of the ICU or HDU. This is protocol. Very important, very learning. But we have the patience to listen to this. Initial evaluation, diagnostic criteria. Initial evaluation, what is that? History and physical examination. Then arterial blood gas, complete blood count with differential. This is investigation, initial investigation. Plasma glucose, blood urea, nitrogen. It is not written here creatinine or urea. They have told blood urea because it indicates more of the hypovolemia, dehydration. Electrolyte, chemistry profile, and creatinine level stat, as well as ECG. ECG is done mostly and test and cultures as needed and start IV fluid. This is initial evaluation. This initial first hour IV fluid at the rate of 1 liter per hour of normal sodium. This is initial evolution and initial start stage of 0 to 1 hour. So diagnostic criteria, we have told it before. So IV fluid, there are 4 headings. You see IV fluid, insulin, potassium, and bicarbonate. As we have told before, determine hydration status. Hypovolemic shock, you give running of normal sodium. If needed, give plasma extract. Usually it is not needed, you can give running fluid, it happens. Mild hypotension, less than 90 systolic pressure. Then evaluate corrected sodium. Sodium is high, even the normal sodium give half strength sodium chloride. Depending on the hydration status. Here it is written 4 to 14 ml per kg. It can be given in the ICU or the ICU, but general word you can give also. If sodium is low, then you give normal sodium. But again, depending on the hydration status, when serum glucose reaches normal, change the sodium chloride to the, as I told, the ketone goes later. So to keep on ketone decreasing, you keep dextrose, 5% dextrose. When blood sugar is 150 to 250, when blood sugar is 150 milligram, and give at the rate of 150 to 250 ml per hour, and adequate insulin. Insulin should be lowered at that time. Or 5 to 10 units subcutaneous every 2 hours to keep serum glucose between 150 to 200 milligram per deciliter until metabolic control is achieved. This portion is very important because most of the time we see that when blood sugar comes to normal, at the normal range, blood pressure is normal, insulin is going decreased to half, and we stop giving or we continue saline, we stop insulin. It is not like that. Whenever it is in this range, you reduce the insulin dose, you add, not replace, you add dextrose with normal saline. This is the rule. Next, insulin. Intravenous route we can use. Subcutaneous IM route, it is not in Davidson. Subcutaneous IM route, they have told IM route is not written there. They have told subcutaneous rapid acting insulin can be given, and they have told if somebody is on long acting insulin or basal insulin, they should continue it because the patient will be primed with insulin, but it is in Davidson meeting. So intravenous insulin, how will you start? It is regular insulin. So 1 unit per kg body weight IV bolus. In Davidson, there is no bolus written. Then you give 1 unit per kg per hour infusion, insulin infusion. It is described in the Davidson how to make an infusion. 1 unit, how to make it. 1 unit per kg per hour, how to make it. You see, we have insulin in 40 per ml or 100 per ml. So if 100 per ml, you take 1 ml. If you take 1 ml and 99 ml like this water, so 100 ml you get 1 ml insulin means 100 units. So per ml is 1 unit like this. So you give 6 units per hour, 1 unit per kg body weight means 6 units per hour like this. So you must know how to prepare it. When I started practicing in this country initially, I saw most of the hospital, even the ICU sister could not make it. Now many of them can make it. We all should learn this. Regarding subcutaneous insulin or IM route, that I told about history of diabetes management in Saudi Arabia. And when we were using in Bangladesh before, when we were in Chennai, we used to give IM insulin. IM insulin always with bolus insulin first and hourly insulin. So, but this, you see, this bolus is not written in Davidson. But what happened? I had a patient in 18 years boy in Levitt. In the evening, I saw him. He was deeply comatose. He was dry like anything. He was respiration from the very far ahead. You could get the smell of the respiration and you see the osmosis breathing. So I gave insulin. At 12 I came. He told, sir, it is not improvement. Then what did you do? That we have given 2 or 3 boluses. 2 or 3 boluses. That patient took 2 days to recover, but he recovered. I have seen this a profound shock, very high blood glucose, and severely deeply comatose patient. But because it was an ICU, the fluid management was very nice. But next, suppose if serum glucose does not fall by 50 to 100 milligram, 70 milligram, that means 3. Tinatorum chuang, 3 or 4 milligram per deciliter in first hour. Then double to reassess double infusion, double insulin infusion hourly till blood glucose fall by 50 to 60, and give hourly IV bolus insulin until glucose falls by 50 to 70 milligram per deciliter. So it is written here to give bolus, and they were correct in giving bolus. Now, same thing happened when serum glucose reaches to 250 milligram. You add with normal sodium or half strength sodium, you add 5% dextrose. And you check, কিভাবে চেক করা লাগবে এটা মনে রাখতে হবে। Check electrolytes, blood urea, nitrogen, creatinine, and glucose every 2 to 4 hours. Initial 6 hours it is told only, then 2 to 4 hours. After it is not practical in our country because we do not do ketone in the blood. We do not do ketone. We do urinary ketone. But in other hospitals nowadays they're bringing after resolution of decay. If the patient is impure, continue IV insulin, supplemented subcutaneous regular insulin as needed. When the patient can eat, initiate a multi-dose insulin regimen and just as needed. But thing is, this is called weaning. Thing is, when patient is normal, sugar normal, ketone normal, eating normal, talking normal, everything is normal, then only we switch over from IV to subcutaneous insulin. This is called weaning. How do we do it? When you give the subcutaneous insulin, last dose of infusion will be given after 1 hour of subcutaneous insulin. How we calculate it? That is different thing. Suppose last 6 or 8 hours you got 8 units of insulin. Make it 24-hour requirement, so 24-hour units. Make 70% in the morning, 30% in the evening, like this. This is called weaning. Now come to potassium. If serum potassium is less than 3 milliequivalent whole insulin and give 40 milliequivalent potassium until potassium is more than 3.3. If serum potassium more than 5, do not give potassium, but check potassium every hour. But it is written also that if urine patient does not pass urine, then until or unless pass urine, you do not give potassium. That is also another thing. Now, we learned that every 500 ml of saline, you give 20 milliequivalent of potassium. This is not written now. Not any book. No book we have got. If serum potassium more than 3.3 but less than 5.5, give 20 to 30 milliequivalent, as we told before. So potassium should be at 4 to 5 milliequivalent per liter. Now assess the need for bicarbonate. If less than 6.9, sodium bicarbonate. If more than 7, no sodium bicarbonate. If 6.9 to 7, sodium bicarbonate 15 millimole, dilute in 200 ml of DA, infuse at 200 ml per hour. Repeat bicarbonate, administer 2 hourly until pH is more than 7 and monitor serum. So this is protocol. This may appear clumsy, but if you fix it on your door, then it will be helpful to you. Practically, you read it, it is very difficult to maintain it, but something should remain when you give fluid, how much fluid you give, how do we start fluid, when you reduce the fluid, when you stop the fluid, how much insulin you go, when you will reduce the dose of insulin, or when you will increase the dose of insulin. you should learn it. Potassium also like that. 3.3, more than 3.3 you start. We learned it 3.5. You start potassium at 20. It is written here 40. And more than 5 you do not give. So more than 3.5 to 5 you give it. So you keep it 4 to 5 like this. Other measures, hypophosphatemia often develop during treatment of decay, but phosphate depletion is of unclear benefit in most cases. If indicated, please do not get bored. If indicated, that means if there is abdomyolysis, if there is hemolysis, if there is neuronal deterioration, potassium phosphate up to 1 millimole per kg phosphate can be infused over 6 to 12 hours. If potassium phosphate is given, serum calcium, because phosphate and calcium level usually decreases and should be monitored. Treatment of suspected cerebral edema. How do you treat cerebral edema? One is hyperventilation, another is corticosteroid, the mannitol, but these measures are often ineffective after the onset. So respiratory arrest is one of the manifestations of cerebral edema. I give you one example. Say, while dengue cases came, a child of 12 years was given 8 liter of fluid. Doctor is telling, sir, I gave 8 liter of fluid, but the hematocrit is not coming down. Actually, see, the parameter of giving fluid is the systolic blood pressure and pulse pressure. Why do you do this? Anyway, he was transferred. He was restless. He was his, he was about to have respiratory arrest. He was taken to the ICU, and all of a sudden we gave the dexamethasone. He became all right in few hours. So this is one of the experience of cerebral edema. So this, I take this term, checklist of decay management milestones, like the children how they achieve the milestone. Then like this treatment also we can check to achieve the milestones of treatment. First is history and physical examination and initial laboratory studies we have seen in the protocol. Then implementing monitoring plan, biochemical and cleaning. Give intravenous bolus of isotonic fluid. Insulin, this is in first 6 hours. Start insulin therapy after fluid is started, only potassium 3.3 and consult the diet. So, do you need to transfer or consult the diabetic team? Yes, if it is available, you should give it. If if it is not available, you should be a diabetic person. Likewise, this 6 to 12 hours. Only thing is, if glucose is 200 to 250 milligram, add the dose and adjust the insulin and maintain potassium. And after 12 hours, continue monitoring and just avoid complication. What is the complication? You see, I have seen 2 or 3 patients. First 12 hours they treated nicely, fluid, insulin, and other things. And after that, he developed respiratory distress. He had clinically pulmonary edema, and the X-ray also showing he has pulmonary edema. Address precipitating factor, decay resolve, stop intravenous insulin, start support. That is winning and consult the educator, diabetes educator. This is available in Bangladesh, in Badam, all the centers it is available. So acute cerebral edema, complication about 1% of decay patients, occurs primarily in children and less of in adults and young adults. Headache and fluctuation or level of consciousness herald this complication in some patients, but respiratory arrest is the initial manifestation in others. The cause is not well understood, but may be related to too rapid reduction in sodium osmolality or brain ischemia. It is most likely to occur in children within 5 years. Decay is the initial manifestation of diabetic mellitus. Children with the highest blood urea nitrogen levels and lowest PCO2 at presentation appear to be the greatest risk. Delay in correction of hyponatremia and the use of bicarbonate during decay may treatment are additional risk factors. এটা মনে রাখতে হবে। This is euglycemic decay, normal glycemia, but that decay. This happens with SGLT2 inhibitors. How do you prevent decay? Complication. Complication usually result from pathological cause of decay or too fast reversal of hyperosmolality or hypertension. Complication include dehydration, include hypovolemia, include hypotension, electrolyte abnormality, cardiac arrhythmia, cardiac arrest, and cerebral. So, information to the patient is what, how did you develop it, how fluid was taken, how insulin was taken. So, how to prevent decay? Just tell the patient, do not stop taking insulin, whatever it is the problem, even if it is vomiting and unable to eat. If female blood glucose value is still greater than 250, when you feel sick, test for urine ketones and contact. Adequate fluid intake are essential during illness, sick days to prevent dehydration fitnesses. The ADA 2015 guideline they have switched over the pre meal sugar level from 3 to 7 to 4 to 8 to prevent this decay, prevent hypoglycemia. So these are the prevention of diabetic complications: skipped meal, delayed meal, non-eating enough, too much medication, more physical activity, drinking alcohol. Now, this is the parameters. I have added HONK. HONK blood sugar should be more than 600. pH more than 7.3. We have seen the pH in DK less than 7. We have seen the bicarbonate less than 15. It is more than 15. We have seen urine ketone 3 are plenty, there is nil or small. Serum creatine 3, more than 3 is unusual here. And here more than 6 in severe case. Osmolality less than 320 here you can allow, but more than 320 is very high. Anion gap less than 12. Mental state mostly is to. I have seen patient with HONK 40 millimole, 50 millimole, 70 millimole, 80 millimoles. 80 millimole patient died before getting the treatment. 70 millimole patient survived, but it took time. Other two patients confirmed they survived. Most of them present with the neurological symptoms. So this is the comparison between DK and HONK. HONK usually evolves over hours to take. You can get bored seeing these tables, but these are important. Every table there is something to learn. Usually no abdominal pain. You see, I told you, I saw the patients, but no abdominal pain. They were mental of condition. Patients usually much older. Most of them were older. None was less than 50. Greater hyperglycemia and volume control. Dehydration was very severe. Greater hyperosmolality with resultant concomitant mental status change. Little or no anion gap. Metabolic acidosis. Mortality rate is very high. In British statistic, it is more than 20%. What is the difference between HONK? The key distinction between the DK and HONK seems to be the fact that in HONK there is still enough insulin to overcome the ketogenic effect of glucagon. Glucagon inhibits acetyl coenzyme carboxylase, which normally converts acetyl coenzyme to malonyl coenzyme. This enzyme, acetyl coenzyme into malonyl coenzyme করে সেই glucagon এটাকে inhibit করে। You see, there is a malonyl coenzyme is going to carnitine, is going to beta hydroxybutyration and ketoxygenation. So, carnitine acetyl transferase is the enzyme. So, it is cut in HONK. And decay it is doing, you see, there is no cut. This place. So in the absence of insulin, glucagon inhibits the synthesis of malonyl coenzyme, resulting in fatty acid, beta hydroxylation, and ketogenesis. You see this cross point, glucagon works here. So there is decay triad and hyperosmolar hyperglycemic state triad. Decay triad we have seen, or hyperosmolar hyperglycemic state triad is severe hyperglycemia along with elevated osmolality, and there is volume depletion. Mostly type 2 diabetes often present following longer or protracted course of illness. Usually those people, though, stay alone. Suppose somebody is CKD, he is staying alone, or his patient is stroke unattended like this. So diagnosis is with blood sugar more than 33.3. As I told you before, I have seen blood sugar 40, 50, 70, 80. There are effective osmolarity 320. As osmolarity here, it is not osmolarity. Absence of appropriate metabolic acidosis of ketonemia. Appreciable. And how do you calculate this osmolarity? So 2 into sodium and millicarbonate plus glucose in millimole. Here they have not taken urea, but previously we used to take 2 into sodium plus potassium, glucose millimole, and urea in millimole. Urea given milligram, so you divide it by 6, so calculate them. Nowadays potassium is not taken into account. Sometimes they do not take urea also. So these are the symptom and diagnostic criteria as I told before. Osmolarity 320, profound dehydration more than 9 ml, more than 9. In DK we say more than 6 liter fluid lost, and bicarbonate is like this. So there is head-to-head comparison. Diabetic ketosis is more common in type 2 diabetes. Type 1 more common in type 2 diabetes. Incidence mortality rate is very high in hyperosmolar hyper. Presentation: abdominal pain, polyuria, polydipsia, dehydration, osmosis breathing, acetone small, and in case of hyperosmolar state, fatigue, altered level of consciousness, hyperviscosity, that is increased risk of MI and stroke and hypotension. Onset in hours, onset in days, and hypoglycemia, it is in minutes. Diagnostic criteria: glucose more than 11, bicarbonate less than 7.3, pH less than 7.3, hydrogen ion concentration more than 50, bicarbonate less than 15, ketone more than 33, or 2 plus ketonuria. Hypovolemia, that means hypotension, marked hyperglycemia without significant ketonuria and significant raised serum osmolality. This is direct measured osmolarity. Now, when you calculate it is osmolarity. Management: fluid replacement, insulin, potassium. It is written state 0.1 unit per kg per hour. Normalize osmolarity gradually. Replace fluid and electrolyte. No insulin. No insulin unless significant ketonuria or acidosis. It is written hold insulin until and unless blood sugar is plateaued. A constant level of blood glucose you are taking. So what are the complications? Thromboembolism, both arterial and venous thromboembolism it can happen, gastric stasis, arrhythmia secondary to hyper or hypokalemia, acute respiratory distress, adult respiratory distress syndrome, AKI, iatrogenic due to incorrect fluid therapy, cerebral edema, hypokalemia, hypoglycemia. And here, MI, stroke, peripheral arterial thrombosis, rare seizure, cerebral edema, central pontine myelinolysis. Central pontine myelinolysis. Same thing. The myelin sheath is straight and there is myelinolysis. In biochemistry, glucose is always they have shown 60, no more than 6. Sodium 135 to 145. In higher tendency, potassium normal. You see, there is A, there is B, normal to high. It is normal. Magnesium normal. It is normal. Chloride normal. Phosphate normal to low in decay. It is normal in HHS. Creatinine slightly high, moderately high. Osmolality 300 to 320, 330 to 380. Plasma ketone 4 plus. Bicarbonate less than 15, normal to slightly less. Arterial pH, arterial PCO2 20 to 30, normal. Anion gap slightly increased. Large changes occur during treatment of decay. In case A means is potassium, magnesium, chloride, and phosphate. Although plasma levels may be normal or high presentation, total body stores are usually depleted. This happens with potassium, magnesium. Large changes occur during treatment. C is what? Sugar. So, and the poor prognostic signs of hyperosmolar hyperthyroidism is hypothermia, hypotension less than 90, tachycardia or bradycardia, severe hypernatremia, sodium more than 160, serum osmolality more than 360 milliosmol per kg, presence of comorbidities. There is another condition, lactic acidosis. We usually encounter. In fact, we used to tell it before, but Davidson, they do not include this in case of hyperglycemic because of hyperglycemic emergencies. So plasma glucose very high in ketoacidosis, hyperosmolar, high in ketoacidosis, hyperosmolar very high, and lactic acidosis variable. Ketoacidosis present both in ketoacidosis and lactic acidosis. Acidosis moderate to severe in ketoacidosis, but it is severe because lactic acid treatment is bicarbonate. Dehydration, prominent variable. Hyperventilation, present. There is no hyperventilation, hyperosmolar, non-ketotic coma. So these are the conditions causing giving ketoacidosis. One is diabetic ketoacidosis, blood glucose elevated. Alcoholic ketoacidosis, normal or low. Alcoholic, it is low. Starvation ketoacidosis, it is also low. Isopropyl alcohol ingestion, it is also low or normal. This is Maimonides, that means philosophy of decay and hyperosmolar hypotension management, initial resuscitation. So fluid fast. And next is diagnostic criteria. Next is treatment. Treatment, insulin on left side is 0.1 unit is more dose, insulin is less 0.05 unit per kg per hour. Then potassium for both. Evaluate potassium every hour when you start body fluid. In case of decay, every 2 hours. In case of hyperosmosis, intubation. Usually less indicated, usually more indicated in compounds. What the bonus parts? Cerebral edema, complication of decay, treatment in pediatrics, hourly neuro check for surveillance, stop fluid, elevate breathing, hyperventilation, mannitol, or the steroid. And euglycemic decay, it can happen with pregnant women with alcohol and taking insulin. So what is the treatment of hyperglycemic hyperketotic state? Please, I'm taking your time, don't get bored. Rehydrated your patient, correct electrolyte imbalance, correct same thing, Actapid you can do it, but monitor and support CVS, pulmonary, renal, and CNS function. See this checklist of decay management, I have shown the milestone. Now let us see the change of milestone in hypersmolar, hyperketotic state. At first 60 minutes, normal saline 1 liter over 1 hour, insulin 0.05, but they are 0.1. Initial investigations, assess dehydration, mental state, sepsis, monitor hourly for 6 hours, then 2 hourly glucose osmolality. In osmolality, in case of ketoacidosis, it is not needed. Urinary catheter or intake output charge. Low molecular heparin initially for prophylaxis and antibiotic infection. 60 minutes to 6 hours, continue normal saline, target osmolality to fall 3 to 8 milliosmol per liter. It is different from there. Glucose falling to less than 5 millimole per hour, initial insulin at hour or adjust insulin and reassess fluid. যদি বেশি হয় তাহলে ইনসুলিন কমাইতে হবে। Maintain potassium as decay. We have learned there 4 to 5, it is written 3 to 6, 3.6 to 5. Avoid hypoglycemia, aim to keep 10 to 15 millimole per liter first 24 hours. Of glucose, if less, comments 5 to 10% dextrose in addition to normal saline. One is your normal saline, one is insulin, another is potassium and glucose maintenance. Monitor fluid balance. And next 12 hours, 6 to 12 hours, continue IV fluid replenishment to target 3 to 6 liter per liter in plus in 12 hours. This continue treatment of underlying treatment, avoid hypoglycemia. 6 to 12 hours, this is finished in case of decay. Ensure clinical and biochemical improvement, measure 4 hourly, biochemistry normalized by 24 hours. Continue IV fluid to replace remaining target. Here it is target 12 beta by 24 hours. Continue IV infusion plus minus DA, avoid hypoglycemia. Same thing, but we are monitoring is more. So this is last thing, checklist of hyperglycemic hyperosmotic state management milestone 12, 24 hours to day 3. This is 3 days, they are in AK it is 2 days. Ensure clinical biochemical improvement and normalization, continue IV fluid and insulin with variable rate of until eating and drinking, convert to appropriate subcutaneous insulin like weaning before, assess for signs of fluid overload, encourage early mobilization, carry out daily food checks. That is food risk indexes, you know. There are charts, food risk index. There are 4 or 5 things. One is your muscularity, one is the neurology, one is food ulcer, one is food deformity like this. So you will have to take these food risk factors. Continue low molecular weight heparin until discharge. Ensure review by diabetes team. They have written diabetes educated. So this is the summary and last slide probably hyperglycemic hyperesmolar state. Diagnostic criteria, estimation of osmolality, and typical presentation and management. Blood glucose level will start to fall once the fluids are started. Do not start insulin infusion until blood glucose level ceases to fall. That means the blood glucose is pre-fluid. It is written in the system. So initial management, you will do the ABCD plus regular observation, ECG, IV access, osmolality, and start production. That is the whole thing I have told today. Hope to see you again next time. My sincere thanks to all the audiences, the moderator, the coordinator, the panelist, and the president. Thank you very much.
Thank you so much, sir, for this excellent presentation.
আমি তোমরা চলে গেছো।
Thank you so much, sir, for this excellent presentation. Now it's time for the question and answer session. These are the questions that you asked during the live session in the comment section. We firstly apologize. We won't be able to answer all of them as the time is short, but we will try to answer as much as possible. Let me request Dr. Rahatapu to start the question answer session. Dr. Samira Rahatapu.
Yeah, thank you, Dr. Kausar, and also thank you, Professor Fazil Azimuddin, sir, for your detailed and rich presentation, as I mentioned before. Due to shortage of time, there are so many questions here. We are unable to pick all of them, so we are choosing only a few of them. Sir, the first question that is important here, the question is, how will we give intravenous insulin where insulin pump is not available?
This is a pertinent question. Before that, I must tell you one thing. It is not a straight card always. One case is DK, another is hyperosmolar, HONG. That is why they have used the term hyperosmolar, hyperglycemic state. It is a spectrum. In one spectrum, it is DK, in other spectrum, at the end of the spectrum, it is HONG. And this happened in my life. I have seen IM injection, I have seen subcutaneous injection, I see IV insulin. So if you have no IV insulin, initially, in fact, I started in saline set. I gave insulin IV. I saw the literature of Americans also using this. They are giving a flask of insulin in the tubes. But answer easy here is infusion set is available nowadays, though it is costly, but not beyond the capacity. Most of the hospitals in Dhaka city it is available. In district hospital, we should get it. It should be available. In case you do not get the infusion set, syringe, 50 ml syringe, then you can use the burette. You see, normally 15 drop is 1 ml. In burette, it is 60 drop. So burette is available everywhere. So if you do not give burette, you give IM or you can give the infusion set also. But this is nowadays not used. So an answer is you can try for burette. Burette is available.
Thank you, sir. The second question is, should we correct sodium level to calculate serum osmolality in HSS?
No, it is the first thing is you will have to correct it. You will have to correct it because there is false level. Pseudo hyponatremia is there. So you will correct it. You take the corrected sodium level and glucose and urea to calculate the osmolarity.
Thank you, sir. And the last question is, how to calculate fluid in decay in CKD or heart failure patients?
Oh, that is a pertinent question also. Because these complicated cases, as I told before, it should be in definitely ICU if possible, ICU if needed. And this is with the central vein. Central vein access should be there and the fluid should be. In fact, in the lab aid, I have seen so many cases. First thing I told you give the central line, you adjust the fluid according to central line and maintain the pressure. That is how it is adjusted.
Thank you, sir. At this stage, I'm very sorry to the viewers that we cannot answer all on each every questions. Due to shortage of time, we have to proceed to our panel of experts. I would first like to request Professor Mohammad Ghulam Kibriya Khan, sir, Professor of Medicine, Dhaka Medical College, retired Professor of Dhaka Medical College, to please give your valuable comments on today's presentation.
Thank you very much. Thank you, Professor Fagan Azimuddin, for his excellent presentation. After his presentation, nothing to remains to comment or add, as he has excellently presented and covers all the corners of the diabetic emergencies, which has been presented. Initially, hypoglycemia, then hyperosmolar, non-specific trauma, and diabetic ketoacidosis. And I would like to thank to the organizers, especially government Bangladesh, SCB Bangladesh chapter Professor Najmul Hassan and Professor Abul Kalam Azad, government elect, and also the chairman of this session, and my good panelist, Kapil Kabir. And I want to, for the learner, the hypoglycemia is very much dangerous and important of all the emergencies of the diabetes, because if it is not identified initially and treated, it will lead to fatality. And when hypoglycemia is symptoms start, if the blood glucose level falls below 54 milligram per DL 3 milligram, then sympathetic nervous system and parasympathetic systems are activated. And if it is not aware, then the neurohypoglycemia develops if it is less than 2.8 milligram, which improves irritability, confusion, blood return charges, and headache, and difficulty in peace. And further loss of glucose leads to loss of consciousness. And if it is not identified treated, fatality will be added. And Hagan Unlimited has excellently presented that this is developed with the minutes to hours, and the decay and internationally developed the blood with later, which allow the time to the doctor to treat the patient. And also, he has covered all these things, so I am not nothing to add anything. With all this, I would like to conclude. Thanks to the organizers, especially SB Bangladesh chapter, and Dr. Prince and Dr. Afroz for his excellent conduction of this session. Thank you very much.
Thank you, sir. Thank you so much for your valuable comments. I would now like to request Professor Mohammad Asadul Kobi, sir, Professor of Medicine, Dhaka Medical College, to please present his valuable comments.
Thank you, Dr. Samira. Many thanks. I would like to thank at first to my great teacher, my Professor Khazana Najimuddin sir. He is directly my teacher as when after internship when I was working as a medical officer of Barden, he was the consultant of my unit. So I feel very much proud and I feel a very I learned a lot of things since then from Barden to now. And today I learned a lot of things from Professor Khazana Najimuddin sir. He covers all the things of acute emergencies of diabetes like hypoglycemia, and at the same time he also covers the spontaneous hypoglycemia, reactive hypoglycemia. These are the very good point, as well as regarding the decay, what are the points, what are the diagnostic criteria. He covers all the things and how to manage, how to calculate the hypoglycemia management and hyperglycemia management in the pump insulin, as well as the how to calculate every aspect he covers in practical manner. So I so grateful to all of this covering by Professor Khazana Najimuddin sir. We know that in our country, every family having a diabetic patient, we must know to how to handle a patients of diabetes and their emergencies. About 8.4 million people are diabetic in our country, according to 2019, and that is about 8.1% according to 2019 by WHO. 8.1% are diabetic in our country. According to number of patients, we are the 10th country. First the China, then India, then United States, then Pakistan, and we are the 10th country number according to number of patients having diabetes. So we must learn about it. We must to face. We must when we are handling a patient of emergency, we must face the diabetic emergency, either hypoglycemia, either diabetic decay, or non-ketotic decay, a non-ketotic diabetic hyperosmolar state. So today's presentation, there are a lot of things, information and practical knowledge we gather. And again, thanks to Professor Khazana Najimuddin sir for his excellent informative presentation. Thank you very much and good night.
Thank you, sir. Thank you so much for your nice comments. At this stage, we are towards the end of our today's program. At this stage, I would like to request our respected Professor Khan Abul Kamal Azad, sir, Governor-elect, SCP Bangladesh Chapter and former President, Bangladesh Society of Medicine, to give his concluding remarks on today's presentation.
Thank you very much, Dr. Thank you very much, Dr. Samira. It is such a meeting when, truly speaking, a teacher, when he speaks and he tries to explain everything related to the topic. A great teacher, Professor Khazana Najimuddin sir, is here today. We are so much proud. We are so much delighted. It is so wonderful to receive a teacher in the SCP chapter's academic session. And also to mention that our two giant teachers, Professor Ghulam Kibriya Khan, a very renowned professor in medicine, vastly experienced, and a very good teacher, Professor Asadul Kabir, they are in the meeting. And I'm very happy to see that a very good teacher, a growing teacher, coming very soon, Dr. Samira. She is moderating the session.
Thank you, sir.
What to be said about the topic and discussion? I beg apology to my teacher, Professor Khazana Najimuddin, because I could not finish in time, so I could not make any comment at the beginning. But I was, with all my busyness and others, I was trying to listen. It was open all the time. I was trying to listen. I was talking to my patient very softly, and rather I was whispering, but I was trying to concentrate on the lecture. The newer generation doctors, they all know that Professor Khazan Najimuddin sir, he has been working in Berlin, but he was our national asset when we were the students. And his passion for medicine was enormous. His compassion for the students was noteworthy. It is me who is the best example. Before my final professional examination, I was very much worried about the final professional. In my college, 20%, 30% students used to pass regularly. We were afraid of so many practical things, especially ECG, X-rays, clinical method. Also, how to summarize medicine. Our great teacher, Professor Khazan Najimuddin, I found him whenever I used to go to ward number 26. I used to find that one man not asking anybody to help him, not waiting for anybody's presence. How many doctors are helping him, but he is there alone. And one day we made an approach. We said, "Sir, we want to learn something from you. We are not very experienced about this type of things." He said, "Okay, I'll give you time at midnight. Come at 12 a.m. You understand that today's students, what the compassion means? He did not ignore us. He was very serious about his ward duty, the responsibility towards the patients. He used to manage the patient first, then his teaching. Then at night at 12, we used to go to the ward. What a wonderful teaching. Very quickly, we could learn so many things where really we were deficient. And that was the way a Professor Khan Abul Kalam Azad was born at the time. If I could not attend those classes at midnight and without any sleep for 2 hours, 3 hours, can you believe this? Whether we'll go for this type of your labor at this moment, doing work in the world for the whole day and night, then teaching the students at 12 midnight. So this is the example of a true teacher. And this is the way how a legend born. And that is Professor Khazan Najimuddin sir. I will not say a single word about today's presentation. I took some screenshots. That is my asset. Really, how to get a good compilation of resources which were mentioned by Professor Khazan Najimuddin. Really, immediately after coming home, I am at home now. Immediately after coming home, I had to go to the washroom, but I could not because at the last part I attended with my full concentration. And I was listening, and I was saying that during our time, we didn't have this type of lectures. Nobody was there to teach us like this. But we have got so many avenues now. The streets are becoming wider and wider, and the students are moving across those streets. They are learning more and more. As they are learning more and more, the streets are becoming wider and longer. So that is the true picture of searching for knowledge. I like to give congratulations and my respect to my teacher. Asadul Kabir said, Professor Khazan Najimuddin sir is his teacher also. I will say that he is not a better teacher to me than to others because he did not teach at 12 midnight to anybody but to me. he is my teacher at midnight. So I learned so many things at midnight from Professor Khazana Nazimuddin. I will remember this for every single moment in my whole life. The contributors to me who created my structure, my all the things what you see today. So I like to pay my respect to my great teacher, Professor Khazana Nazimuddin, also as the governor-elect, and also I have got the opportunity to chair such a session where Professor Khazana Nazimuddin speaks. And also I do believe that in future also we'll get several Professor Khazana Nazimuddin. Then we'll say that yes, we have got teachers like Professor Khazana Nazimuddin. So I'd like to give thanks to everybody who organized this meeting and also to Dr. Prince because he is our another great GM who can make a very good beginning and ending. So with these few words, I will say the diabetes. Every day we are learning diabetes. We have to go on learning, and there was some snapshots of diabetes. Thank you very much, Dr. Samira. I'd like to conclude here. Thank you.
Sadly, we have come to the end of today's program. We have learned so many essential things about the emergencies in diabetes mellitus from Sir today. Many thanks to the speaker, the chair, the panelist, and last but not the least, the moderator Apu for managing time for this program from their very busy schedule. I'd like to thank all the audience who were with us throughout the events, especially those who asked very interesting questions. Hope you got your answer. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole program on the YouTube right after the live session finishes. Our next health talk on acute medicine will held on 28th of October, where Professor M.A. Jalil Chaudhary sir will discuss on a very important topic, which is acute severe asthma. So, see you all in the next episode. Until then, take care and good night.